First of all, I think it's important to remember that options matter for patients. So in myelofibrosis and MPNs more broadly, these are chronic diseases, and patients are living for decades in relatively stable health. But knowing that there are options over time if something either stops working or their disease progresses, knowing that they can sequence through a few more options and maybe even some newer combinations that are interesting brings a lot of hope and promise for patients, gives them some comfort as they navigate their journey through their disease.
Couldn't agree more. Yeah, I mean, I think the key to treating myelofibrosis in particular is you really need options to tailor the therapy. So it's not really one treatment fits all. So whether it's a monotherapy, a combination, or when to switch and which agent to pick really is individualized for the patient. So the more options we have as physicians, the more likely we can tailor and optimize the treatment for an individual.
Yep, that's our motto. Options matter. And even adding to the symptoms themselves, we at MPN Research Foundation have recently done a study of surveyed some of our patients. 676 patients responded and came back and said what their goals for treatment are, and it is improved quality of life. 50% said improved quality of life, and more specifically, 40% said relief from symptoms. Is their primary goal for treatment. And so I think these options that are coming online, the combinations and the ways in which we're looking at how symptoms are being measured and managed, I think is very important to patients.
Absolutely. And symptoms are complex, and then you and I have had this conversation before. Yeah. Sometimes it's hard to measure symptoms. It's hard to measure the actual benefit or absolute benefit of a given therapy or combinations with symptoms. So it's definitely been an area in our field for drug development where we're trying to figure out what is the best way to capture that benefit for any individual patient, because some patients may benefit to greater degrees than other patients, and not all therapies are ideal for any given patient. So it really is a complex world that we're living in terms of trying to actually navigate this. But clearly patients are symptomatic. They want to feel better. Physicians want to make patients feel better, but we also want to extend survival with good symptomatology. So it's sort of a mixed picture. And for some patients, the symptoms may be systemic symptoms, cytokine-driven symptoms. For other patients, it may be more spleen-related symptoms. So, even the symptoms part is complex because it could be different symptoms driving for any individual patient. And how best to measure that is really, I think, an interesting topic that's evolved over time. And years ago, we were really sort of binary, whether you had a 50% reduction or not. I think now we're sort of moving into an area where we're looking at absolute changes in symptoms, and that might be a better way of actually gauging symptom benefit. And it's always not always, but it's often in the context of how much spleen we've reduced, and then looking more broadly at other biomarkers, trying to get a sense, are we really changing fundamental aspects of the disease? But as you and I and others have had discussions, at the end of the day, we're really hoping that we're not just improving symptoms here, today and tomorrow, but also down the line that we're changing the disease course to extend outcomes and improve survival. One of the fundamental deficiencies, I would say, in our field, and we have meetings centered on this, is the fact that right now we really measure spleen and symptom reduction as our primary endpoints for clinical trials, because that's what we started the field in with JAK inhibitors, and they're really good at doing that. They don't do it for everyone perfectly, and they don't always maintain it for every patient indefinitely. So that's some of the nuance. But we are moving into an area where we're looking now at therapeutics that are anticlonal that might be able to change the natural disease history. And the problem with the trials we design often is that we don't follow patients, because you need a lot of patients, you need a lot of power to do it statistically. We don't always follow them to the point where we can confirm survival. So we are in a desperate search for surrogate markers that you can look at earlier on, right, whether it's spleen reduction or symptom burden even, or bone marrow fibrosis reduction, driver mutation reduction, cytokine reductions, things that you can measure maybe at a 6-month period that may correlate and associate down the line with a survival benefit. So it's really, I think, key for us as investigators, and the Research Foundation brings us together and patients to figure out how do we do that as a group so that we're not at the stumbling block where we're trying to understand, what are we really achieving?
Yeah, and I think you bring up a really good point about the time that it takes to actually measure that, as well as the amount of maybe data that we need to actually start to measure that and identify what some of those surrogate markers might be to be able to, whether it's measure progression or just overall disease modification. And so we at the foundation are looking at different ways that we can attack that data problem and see can we aggregate generate more data and understand the clinical markers that patients have experienced over time to be able to build that body of evidence and identify some of these surrogate markers.
And I think the point of we need to work together is so key, because in these rare diseases, if we work in silos, it's not going to be effective to move the field forward. So even things that aren't so simple, but like pooling data, whether it's patient level data, the way that you guys pool it from patients that are providing their data, and that's a generous and ambitious, endeavor, because that becomes very important, because that's real world data. Or if it's taking prospective data from clinical trials, pooling it together so that we have the power to ask these questions. Because right now the trials we do in MF, PV or ET are relatively small trials. They're not thousands of patients trials. We need to pool data. That means sponsors also need to be, I don't know what the right word is, but to be generous is probably not the right word, but to be
forward-thinking.
Forward-thinking, and and I do think I do see that. I mean, I do see the sponsors that are investing in this area coming together at the table. We have initiatives to try to pull prospective data together to ask these questions, particularly in the setting of JAK inhibitors, which is sort of the first line of therapy. I think what's exciting now is that we are trying to move beyond JAK inhibitors or combinations of JAK inhibitors. We do have, I think it's important to mention, we do have at least one clinical trial, which is a randomized phase 3 trial in the relapse refractory setting that is looking at survival as an endpoint, and that's unique. So imetelstat in the randomized phase 3 study is looking at a survival endpoint. So I applaud Jaron and the team for going after that endpoint. That is important to patients and physicians, obviously. And now there's a whole number of really, I think, active agents that are rational, that have been combined with ruxolitinib or are using after ruxolitinib failure to try to push the envelope and improve outcomes. And we need to be patient, obviously, to see these things through and follow them through. There's a number of trials ongoing right now that are evaluating a novel mechanism-based therapeutic with ruxolitinib in the JAK inhibitor-naive patient population. So we've seen drugs like navitoclax, the BCL-2/XL inhibitor, come through with really actually nice results, but sort of failing on that key total symptom score at 24 weeks. Pelabresib, the pan-BET inhibitor, also really great data, but not quite hitting that TSS at the 24 weeks. And now we have a trial called the Sentry study, which is selinexor, the XPO1 inhibitor, which is actually an approved therapeutic for myeloma and B-cell malignancies, but repositioned towards myelofibrosis because it does have certain MOAs that are relevant to the pathobiology of the disease, and has pretty interesting and compelling phase 1 study in a relatively small number of patients, but took notice, very significant spleen and symptom response and tolerability, that then provided the confidence to go into a large randomized phase 3 study. So the Sentry study is an ongoing global effort to evaluate selinexor plus ruxolitinib versus ruxolitinib plus placebo in JAK inhibitor-naive patients. And most recently, an interesting development in that study as it continues to move on is a change in some of the endpoints. So the primary endpoint remains spleen volume response, which has sort of been standard. And now the other primary endpoint or key endpoint is reduction in mean absolute change in symptom score. So rather than sort of a binary, you either hit a TSS 50 or you don't, it sort of takes into fact that patients come to you with different symptoms and different symptom severities in each symptom, and that maybe the TSS 50 for one patient may not reflect the full benefit for another patient. So looking at the mean change from baseline to week 24 may be a better way of really assessing the true impact. What these studies are doing, Sentry being one of them now, or probably the first one to do it, is anchoring that change to a measure like patient global impression of change, another way of determining that change between the two arms in the mean score is actually clinically relevant, that the patients appreciate that change. So I think it's exciting because it's not just exciting for the Sentry study, which it is, but it's exciting for the field because it also indicates a willingness of the FDA to entertain endpoints and to soften the idea that it's just a binary endpoint. So I'm excited by that. I think for patients and other sponsors will likely be excited by that.
And I think from the patients that we represent, I couldn't agree more as well, because all three of those programs that you mentioned had some form of symptom score response that we had to address. And if you think fundamentally back to what myelofibrosis and MPNs are broadly, they're very heterogeneous diseases. And that means something biologically, but to the patient, from the patient experience, what that means and how that shows up is that they experience their disease very differently. Yeah. They experience their symptoms very differently. And headaches to one patient means something very different to another. Bone pain from one patient means something very different to another. So what we're most excited about is the innovation, or the evolution, I should say, of the looking at total symptom score in different ways actually acknowledges the fact that those patients experience things very differently, and we're taking a much broader lens at how we characterize those symptoms, which I'm excited about, because I think that also is a precursor to the ongoing conversations we need to continue to have with the regulatory authorities about now how do we look at our endpoints even more broadly, so that we are coming back to the patient and giving them endpoints that are meaningful to them and recognize the variability in their patient experience and in their treatment journey.
Yep, absolutely. And I think from the FDA standpoint, I appreciate the fact that they are charged with an objective to allow new drugs to come forward that have tangible benefit to the patient. And spleen volume reduction alone, unless we can prove associates with survival, symptom improvement is something that I think everyone around the table agrees, and obviously patients will tell you, is really important. How to capture that is the nuance we're talking about. But what I'm also hopeful for is that the way we're looking at this will also evolve over time as we understand what these biomarkers are telling us, so that if we see that adding a drug, so ruxolitinib we know is a great symptom improving drug. It is hard to sort of improve symptoms beyond that. But I think as long as we're not worsening symptoms and adding some benefit, and then we can validate that biomarkers maybe early on are also changing the disease for later outcomes, I think it creates a nice picture where we could find pathways forward. So I'm really excited that we're hopefully moving in a more positive direction.
Yeah. And I think the momentum behind that direction comes from the entire community coming together, as you were saying earlier, that patient voice, the research and clinical community, as well as our industry leaders and the sponsors who are bringing these treatments over the finish line, are coming together to address that and try to gain some momentum to move forward that conversation with the regulatory authorities.
And I think right now, selinexor as a combination up front looks like a very promising opportunity to sort of deepen responses early on. But we don't really know whether the best approach is to get the deepest response up front or to reserve even therapies in the second line. So there are some unanswered questions. And then, the idea of maintenance therapy I think is really intriguing in chronic diseases like the ones we're talking about, but I don't think we really know how to maybe induce a response and maintain a response. I think those are all open questions. There are a subset of patients, maybe 10%, maybe even a little bit less depending on where you practice, that will go on to transplant, the only curative option we have. Right. So one unanswered question would be, is it possible that if we synergize drugs like selinexor and ruxolitinib, navtemadlin, ruxolitinib, these therapies that clearly have very anticlonal activity, can we get deeper responses so that ultimately that subset that might go to transplant, or even patients who may not have gone to transplant, become more attractive transplant candidates, may do better with transplant outcomes? So a lot of unanswered questions. I think it's paramount, as we keep saying though, that we need to be committed, the patient community, the physician community, the sponsors, everyone committed to following patients through. Otherwise we don't know what ultimately happens. We look at these very short outcomes, 6 months, and that's not sufficient. We owe the patients more actually to follow them out, so we really know the full benefit of what we're doing.
Right. And our hope is with our relationship with the patient community that we can keep them engaged and informed, because this is a very empowered and committed patient community that wants to track their progress and know their outcomes, because these are longer term, more chronic diseases. But coming back to sort of all of the excitement of all the programs that you talked about, and the question about what does this mean for the future, I think what I heard in all of that was back to options matter.
Yep.
We are bringing more options, single agent options, combination options, new mechanisms of action. And what that also translates for patients is not only will I be able to have more options over the course of my disease, but that might also mean I can actually start some treatments earlier. And if we could learn more about it, if we're starting treatments earlier, does that mean they are having better outcomes downstream and changing the course of their disease by starting treatments earlier because they have more opportunity to sequence later?
And that'll be my opportunity to take the pitch. Because there are so many questions and we don't have these answers, I really think it's paramount for, when possible, for patients to participate in clinical trials. Because in these rare diseases, when we do anecdotal sort of treatments outside of the paradigm, we don't really learn from that, and it doesn't actually benefit the greater patient good. So I always admire patients that go on clinical trials because it takes a certain degree of courage and faith to go on a trial. I like the trials we're doing these days because they don't really take patients away from standard of care, and I think that's really important for patients to appreciate. You get standard of care plus either a placebo, so you're not robbing anyone from standard of care, or the study drug, often with options for crossover. So I would really implore patients, easy for me to say, but I implore patients to seek out those clinical trial options in these rare diseases. I think the care is better when you're on a clinical trial. I firmly believe that. I think the outcomes are probably better because you have much more attention, there's much more rigor to the treatment. And usually clinical trials are done in centers where there's a lot of expertise in these diseases. So I'm a biased person saying it, but clinical trials.
No, absolutely. I think we spend a lot of time with our patients educating them on why clinical trials should be an option for them, sort of dispelling some of those myths about it being a last resort. It really is part of a proper standard of care. But I'm going to take the opportunity to call our clinical community to action because coming back to the survey that we just did, of those 676 patients, of which a fair number were actually seen at academic medical centers, only 14% of those patients said that their doctor had ever discussed a clinical trial option with them. So my call to action to the clinicians and the treaters out there is sit down with your patients and look at their clinical trial options and see what's right for them, because there are lots of new options out there. And I think we should be, as you said, thinking about this as more part of their standard treatment plans.
Absolutely.